Everybody hear me? I think so. My name is Dr. Norman Fleischer, and I'm Director of the Division of Endocrinology. And my contact information is there, Norman Fleischer at einstein.yu.edu. And my phone number is 718-430-3187. I'd be happy to communicate with anyone who has a problem with the course or having any specific questions. I'd be happy to do it. Okay. So today we're going to begin, I guess this is the second and third lectures of your endocrine pathophysiology course. And the first couple of slides I have really relate to our introduction, which I am confident that Dr. Epstein has already covered, so I'm going to skip them and go right to the subject of today's talk, which is essentially the hypothalamic pituitary, both its physiology, pathophysiology, and the common diseases involved. This is a schematic representation on this slide of the pituitary, which sits in an indentation in the sphenoid bone called the sella turcica, which has an anterior and posterior clinoids. It is tightly separated from the normally the brain by a tight reflection of dura called the diaphragmatic sella, and extending through that dura is the anterior and posterior and anterior pituitary, connected via that stalk to the brain, particularly the hypothalamus. And as you'll see, both nerves and blood vessels flow through that. In the sphenoid bone is the sphenoid air sinus, which is a critical, as you can see, and we'll see it later in other views, is a critical an anatomical structure because it allows us ready surgical access to the pituitary fossa. The anterior and posterior walls of the pituitary are bony, as reflected here. The medial and lateral wall of the sella turcica are simply dura, and therefore there's no separation from the cavernous sinus, which is on either side of the, and we'll see this in more coronal views in a minute. Here the marvelous, as you can see from my gray hair, I've been doing this a long time, and I can't tell you what's different. I mean, things like progress in radiology and other advances over the years has made this an amazingly, in some ways, more simple process. But here we see on an MRI, on a sagittal section of an MRI, we see the sphenoid sinus, we see the stalk, the anterior pituitary, and the posterior pituitary, which shows up on MRI as small and also as a very hyper-intense structure. This is the optic tract, so you can see that we're near vital structures in the brain when we talk about the pituitary. Here is a sagittal, a coronal section of a human brain. Actually, this is a very famous endocrine pathologist by the name of Sheehan. This is a picture made by him in the 1800s. And as you can see, the pituitary gland looks like a bean with a convex upper border. The stalk is right there. This intense thing is the optic chiasm. The cavernous sinus on either side, again, remember, it reflected only by a dural separation between this. In the cavernous sinus, as you know, are the carotid artery, jugular vein, 3, 4, and 6 cranial nerves. So you can already get a picture of what happens when we have diseases that affect, particularly if they enlarge the sella turcica. Here's the sphenoid sinus just under here. You can see how you could, if you can approach that through under the lip or through the nose, you could just chip away the upper border of the sphenoid sinus and you would be entering into the sella turcica. And that's done. Here we see that we can, just as almost as clear as Sheehan's picture of his, we can see this, all of these same structures on a coronal MRI. There's the optic chiasm, the stalk, this slender little thing here, and there's this bean-shaped thing. Under it is this clivus. That's really not important. The flow voids of the carotid artery are on either side. I think you can appreciate those. And then again, we can take a close-up view of what Sheehan said and then showed, and then here we see the close-up view on the MRI. Here's the void. This carotid artery, stalk, optic chiasm. The embryology of the pituitary gland is really interesting in that it is a combination of an indentation from the floor of the diencephalon and from the primordial roof of the mouth and evagination, which come together and form the neural structure, forms the posterior pituitary, and this endodermal forms the adeno or the anterior pituitary. Notice as part of this, the little cleft cyst that's left behind of the pituitary of the Rathke's pouch, and we see periodically a formation of a Rathke's pouch cyst, which can be quite large and present actually as a fluid-filled mass within the sella turcica. Kind of if you remember the embryology, you understand why it can happen. The anterior pituitary produces a number of hormones. It's a multiple organ. It's the size of a bean, and it's multiple organs. There are cells, specific cells that produce ACTH, TSH, FSH, LH, prolactin, growth hormone, and in the posterior pituitary, antidiuretic hormone and oxytocin. And the interesting thing is that whereas the cell bodies or the cells making these anterior pituitary hormones are, of course, are located in the anterior pituitary, the cell bodies that make both ADH and oxytocin are located in the hypothalamus. And the axons from those nerve cells then accumulate and form the posterior pituitary. And essentially, you don't destroy these cells by removing the posterior pituitary. And of course, the function of these cells we're going to talk about in some detail. Just as a very schematic, ACTH stimulates the adrenal cortex, TSH stimulates the thyroid hormone, FSH and LH affect the testes or the ovary, depending on the gender. Prolactin is essential for lactation. Growth hormone has a number of effects, but essentially it regulates growth and some other things. We're going to talk in detail about a lot of these things. Oxytocin in the human is not a critical, it's so critical, but it's involved, of course, in uterine contraction and in the letdown of milk. And antidiuretic hormone we'll talk in some detail about in the course of this lecture this morning. So in terms of the pituitary hormones, they represent three classes of proteins. ACTH is really a 39 amino acid peptide that is derived from a very large 39,000 molecular weight precursor called POMC, or pre-opiomelanocorticotropin. And from that, a variety of hormones are made. Really, from the standpoint that we're going to talk about today, it's only ACTH. In the pituitary, ACTH is made in the hypothalamus due to the fact that other peptide convertases or exist, ACTH is also split into alpha MSH and other proteins. But we're not going to discuss that today. In other words, today we're going to talk about the hypothalamus, when we talk about the hypothalamus, as it relates to the anterior pituitary. Of course, all of you now know from neurology, neuroscience that you're taking, have taken, that the hypothalamus has a lot of more functions than simply regulating the anterior pituitary, has a lot of related to feeding, metabolism, and a lot of other functions. But they're not the subject of today's lecture. So ACTH is derived out of this large peptide. There are 3 glycoprotein hormones, that is to say, proteins that contain carbohydrate. And that's LH, luteinizing hormone, FSH, and TSH. And these all share another hormone made by the placenta called human chorionic gonadotropin, HCG. All 4 of those hormones contain an alpha subunit which is identical between all of the 4 hormones, the 3 from the pituitary and the 1 from the placenta. And then their specific function, though, is on them because of their differences in their beta subunits, which are similar in size and yet have enough structural difference to make them highly specific. So there's not overlap between these functions, except HCG, essentially, even though it's structurally different, is basically has the same biological function as LH. And there's some overlap between those and TSH. Somatomammatropins are growth hormone and prolactin, and they are similar, as you see, in molecular weight and in amino acid composition, but have distinct functions. Even though prolactin cannot occupy the growth hormone receptor, growth hormone can occupy the prolactin receptor, which is not very usually not clinically significant, just kind of interesting biochemically. And of course, this just tells you the evolution, of course, of these hormones, if we were to think back. So each of these hormones are produced by a distinct cell. They're not overlapped, though in some tumors there may be some overlap. But in normal cells, 1 hormone, 1 cell. Now, this slide illustrates the vascular nature or the vascular supply to the anterior and the posterior pituitary, and a number of important distinctions to be noticed. Number 1, as you can see, the suprahypophyseal artery and the inferior hypophyseal artery, and I really don't care if you remember those names or anything, but they basically develop into a capillary bed, either usually in the hypothalamus, here a little bit in the posterior pituitary, and then recollect into something called the portal system. And like from the hepatic portal vein, there is a hypothalamic pituitary portal vein, and roughly 80% or more of the blood supply to the anterior pituitary is derived from this portal system, low pressure portal system. Now, it was pretty obvious to anatomists many years ago, before we knew very much about the structure of a lot of things I want to tell you about today, that this was a unique situation, and it must have some physiological significance. So they did things like take the anterior pituitary, remove it from the cella turcic of a rat, and retransplant it under the renal capsule and let it essentially revascularize and flourish. And so it was perfectly viable. And they noticed then, they looked at the issue of what happened to the hormonal production of all these different hormones I'm telling you about. And what they discovered was that every hormone produced by the anterior pituitary, the ones I've discussed, their production fell to 0, except for one, prolactin. Indeed, prolactin rose. So the actual production of prolactin increased when you removed the pituitary from the sella turcica out away from this hypothalamic vascular situation and put it independently with its own arterial blood supply. And hence the concept, which is absolutely correct many years later, was that essentially there are a number of trophic factors produced in the hypothalamus which stimulate the anterior pituitary to work, but in one case, prolactin, the actually must be a major effect of the hypothalamus is to inhibit its production. And you'll see how we use this clinically and we understand all this quite well at this time. The original attempt to find these factors, which essentially are modified in the hypothalamus, which regulate the anterior pituitary, was a major scientific effort that took place in the 1950s and the 1960s. And I remember, because I was at this, not in the 50s, but in the 60s, I was in the laboratory next to where one of these, a bunch of these were finally discovered, and for which the Nobel Prize was won. And that was this is before the days of genomics, and a two-story column of G. cepheidex, G50 cepheidex, for any of those here who have ever done column chromatography, through 2 stories, and 250,000 sheep hypothalami were extracted with acetic acid and poured through that column as the initial purification step to find some of these factors. And it was successful, both in terms of what we now understand. And those factors are now well described and well known, and they're sort of listed in as thyrotropin-releasing hormone. These are now all products of neurons within the hypothalamus, which travel through that portal system to influence anterior pituitary function. Thyrotropin-releasing hormone, gonadotropin-releasing hormones, which regulates both LH and FSH, corticotropin-releasing hormone, which regulates ACTH, growth hormone-releasing hormone, which releases growth hormone, dopamine, which is a classic neurotransmitter, not one of these modified neurotransmitters, but a classic neurotransmitter is the inhibitory factor involved in prolactin. And another hormone in the hypothalamus, somatostatin, inhibits both growth hormone and TSH. And as we'll see, it has a lot of effects outside of the anterior pituitary. Indeed, without getting in any really discussion of it, there are other places in the brain and maybe in the GI tract where several of these can be found to be produced. But today, and so I want you to think of them as modified neurotransmitters in the area of the hypothalamus. They are major regulators of pituitary function, and that regulation, as you might imagine, is complicated, but we'll simplify it for you. From the posterior pituitary are hormones that are directly secreted into the circulation. These hormones in white, are basically, from our standpoint, made in the hypothalamic neurons, come through the portal system, released onto the capillary beds, and perfuse the anterior pituitary and regulate anterior pituitary production. ADH and oxytocin are directly secreted from the posterior pituitary. They're made in the hypothalamus like the others, but they travel through their axons directly and are secreted. And this is the original concept of neurosecretion. And indeed, the original the discoverers of this neurosecretion really are people who were a part of the original faculty of this medical school, having been sort of forced to leave Germany in the 1930s and ended up here, and were very famous members of the National Academy of Science. This is the structure of these different hormones. I don't think you need to know this in any sense of the word, But notice that TRH is only 3 amino acids. GnRH is not very many. All these are small peptides. CRH and GHRH are a bit larger. And somatostatin acts not only on the pituitary, but has a tremendous number of extra. It inhibits a number of the secretion of a number of GI hormones. And indeed, it's not only produced in neurons in the hypothalamus, but it is produced in specialized cells within the pancreas and is part of the islets of Langerhans and has a very profound effect to inhibit insulin secretion and glucagon secretion. In fact, it may have it's a very important role in that sense. This is the structure of the 14 amino acids of native somatostatin, and as we'll see, there are a number of, there are basically 5 receptors for somatostatin. They vary in density in many set places in the body in which receptors of those 5 are expressed. And a lot of pharmacological biochemistry has gone in to make derivatives of this hormone that have variation in specificity for these receptors. And this is useful clinically. There's one of them here, octreotide, which we'll talk about in some detail. Another one that's just come on the market is pasireotide, which it basically has different affinity for certain of the receptors to either the native or the octreotide. And these are clinically used, and you'll see how we do use them a little bit later in this lecture. Now here is therefore a schematic slide of how the regulation of pituitary hormones are made by these different hypothalamic peptides. As we said, CRH is the major regulator of ACTH secretion, but independent of the CRH, there's an additional factor, namely ADH, or arginine vasopressin, which is another name for antidiuretic hormone. Also, under stressful conditions, will also stimulate ACTH secretion. GnRH, as I've already mentioned, stimulates both LH and FSH, which is interesting because these cells, the LH and FSH throughout the normal menstrual cycle is not concurrent. It's not absolutely the same. So we also are introducing the concept that there's variation of this secretion beyond simply the hypothalamic regulation. We'll comment a little bit about that, but I won't comment a lot simply because you're going to have, following the course in endocrinology, you're going to have a course in reproductive biology, which is going to affect this, be able to discuss this in more detail. But we're going to just talk a little bit about it. Growth hormone releasing hormone stimulates growth hormone. Somatostatin inhibits it. And these neurons sit next to each other, and there's a positive and negative effects on growth hormone secretion by these two different things. Somatostatin also affects TSH secretion, but this is not clinically relevant. TRH is the major effector of TSH secretion and causes a positive effect on it. And prolactin, we've already talked, forget that VIP, I don't know what that's there for, but dopamine has a negative effect. Many things have positive effects on prolactin, but you know, I've already told you that if there's nothing there, prolactin does fine on its own. In other words, there's no hypothalamic influence. Prolactin is high. Therefore, whether you can show something in an experimental animal, but really it's not important. Dopamine is the major regulator of prolactin secretion. And of course, you're going to have different days on the adrenal, on the gonads, on thyroid, and on breast. And today, we'll actually talk mainly, though I'll give you some basics, but I'm going to talk mainly about prolactin and growth hormone in terms of diseases and about just diseases in general of the pituitary. I think that Dr. Epstein has already discussed with you the concept of negative feedback. I'm sure he has in the introductory course, but the concept is illustrated here. Hypothalamus, which receives inputs from the brain and also from the periphery, stimulates releasing and inhibiting factors. The pituitary then sends trophic hormones to target organs. Target organs products then feed back at the level of the pituitary and or the level of the hypothalamus or even higher centers to regulate. So it's a thermostatically regulated negative feedback, much like the thermostat in your home that reads the temperature and tells whether to turn on or off depending on where the set point is for the secretion. And that's a very critical concept within endocrinology, and you'll see and how we not only see examples of it, but you will also see how we use it diagnostically. Now, I'm not going to say much about the thyroid because you're going to have a whole lesson, a whole session like this one on the thyroid, but we'll talk just basically to point out that TRH stimulates the production of TSH by the thyroid. The thyroid produces T4 and another hormone, T3, and they have the negative feedback mainly at the site of the pituitary, and I think I won't stop any more about that. Here we show you just clinically how this works, in the sense is if you look at time 0 here in patients who have no thyroid gland, they have very high TSH because they don't have the negative feedback of the products of the thyroid gland inhibiting TSH. If we gave them TRH, it would even go higher. You can have mild hypothyroidism, you still see an elevation of the TSH. If you had no pituitary at all, you would see a lowish TSH and no effect of giving the hypothalamic releasing factor simply because there's nothing there for it to work on. But if there was a hypothalamic lesion, you could essentially normalize TSH by giving TRH. And indeed, that's been shown in a case report of a child who essentially had a mutation such that they did not produce TRH. They were hypothyroid, and by giving repeated doses of TRH, you could establish the patient to be euthyroid. We don't usually use releasing factors because we can just give the thyroid hormone itself. Growth hormone, a gonadotropin-releasing hormone, is very interesting in it's secreted in almost like a pulse generator. That is to say, you see amplitude and pulses. The pulses have frequency as well as amplitude, and these regulate differently the secretion of the hormone, LH or FSH. And that's one of the mechanisms by which we dissociate LH and FSH secretory patterns because of the variation in the frequency and or pulse amplitude from this almost pulse generator. And here we show an example of that. Here is a goat that has had a plate separating the hypothalamus from the pituitary, and the portal vein cannulated. I'm sorry, it's not a plate. It was just cannulation. It's a perfectly normal goat, other than he has a cannula in his portal vein, hypothalamic portal vein, as well as in his peripheral vein. And as you can see these pulses over time in LH secretion in black dots. And if you look at his portal GnRH concentration, you can see it basically parallels that. That is to say, these pulses are in response to these pulses generated of GnRH. The other thing that's interesting about GnRH, it travels quite an interesting course. Embryologically, it's formed in the olfactory placode, which is the same place that cells degenerating for smell are generated, and it migrates through to the hypothalamus, requiring a whole series of genes that are both chemoattractive and repulsive factors, eventually landing in the hypothalamus, where it again is affected and connects neurally to a number of pathways. And then, of course, it then generates pulses to the anterior pituitary to secrete both LH and FSH. And many genetic diseases or people with gonadotropin deficiency have been determined who are missing GnRH neurons simply because one or more of these chemoattractive factors have been missing. Now, the reason I bring this up is the connection between olfaction, one of the most classical diseases of isolated gonadotropin deficiency is called Kallmann syndrome because missing a gene called Cal1 that's very critical for this migration to occur. And then I always can't help but think that this relationship between olfaction must have something to do with a lot, like perfume and other things, between the effect on reproductive behavior, etc., that play a role in this connection between gonadotropin secreting cells and olfaction. The other thing about this pulse-generated concept is here we show an animal now that essentially has no hypothalamus. In other words, it's been removed from the circulation completely. Again, this is the one with the plate put in. And if you give pulsatile GnRH, both LH in black and FSH in the white circles, normalize, the animal can ovulate, can be fertile. However, if you can turn this into a continuous GnRH infusion, you downregulate this system and you actually develop infertility and no gonadal function. And then you can turn that on the pulsatile nature of the secretion and up comes normalization. And this is used clinically. You can give a long-acting GnRH analog that has a month's duration of action and actually downregulate the system. And it's been used to treat prostate cancer. It's been used to treat women who are infertile and who you want to get rid of their own gonadotropin secretion, so you can then give your own and your own sequenced events so as to induce fertility and many other types of use. So using this kind of physiology to medical secretion, to medical use. Now we turn to one that we're going to spend a lot of time on, namely growth hormone secretion. So as I've already indicated to you, growth hormone is regulated from the anterior pituitary by two hypothalamic releasing factors. One is growth hormone releasing hormone and the other is somatostatin. There are neurons that essentially feed this to each of these to the anterior pituitary, and their balance has a lot to do with the secretion of growth hormone. Growth hormone has effects, and we're going to talk about those more, in many tissues in the body. In addition, another peripheral hormone called ghrelin, G-H-R-E-L-I-N, is secreted from the stomach, and it goes up and also stimulates pituitary secretion. Now, this is a very interesting hormone in that, look at it, the name of it, GH-rilin. So it actually was named as a growth hormone releasing hormone, and it was actually, someone discovered that there's other things besides GnRH, GHRH, that would stimulate growth hormone secretion, and they said, well, there must be a receptor for it. And if they found the receptor, they said if there's a receptor, there must be a natural ligand. They found the natural glilan, and they named it GHRLEN. It's a natural growth hormone releasing. And then they looked at where it was in the body, and it turned out to be in the stomach mainly. And furthermore, when they gave it to people, growth hormone went up very much, but the people also gained large amounts of weight. In other words, and we now know that what it says is it's secreted from the stomach when your stomach is empty, and it goes down when your stomach is full. So it's a satiety signal. It tells your body to eat when you're hungry. It's when you need food, it is secreted. And it sort of says eat and also make growth hormone, because when we want to have people growing is when they're eating, right? I mean, so that's sort of an interesting phenomenon. Now, how does growth hormone work? Notice I put down here, do not memorize. I hope you know something about these kind of pathways, because they're very involved in many aspects of biochemistry of the body, not only for growth hormone, but for this course you don't need to know other than the fact that the growth hormone receptor essentially is it's more or less a cytokine receptor. Two receptors are dimerized by binding to the ligand, growth hormone. And growth hormone binds to these receptors at two different sites, but it essentially effectively dimerizes them. It activates them. There are, of course, are phosphatases and phosphatative pathway, the MAP kinase pathway, to increase the production of a series of proteins in the liver, but in many other cells in the body. The main one we want to talk about is IGF-1, insulin-like growth factor 1. That is the main factor that growth hormone generates that causes growth. It also increases a insulin-like growth factor binding protein 3, and these have to do with binding, and we're not really going to discuss this very much at all, but IGF-1 we're going to discuss. And this results in cell proliferation and a number of factors. Liver is a common source of making this, but other tissues make it as well. And that's how growth hormone works. The receptor for the reason it's called IGF-1, insulin-like growth factor 1, is its receptor is very similar to the insulin receptor. And there's even crosstalk between these two receptors, in that IGF-1 at high enough concentration will activate the insulin receptor, and insulin receptor will also activate at high concentrations the IGF-1 receptor. There's another compound called IGF-2. We're not going to talk about that today. It's not regulated by growth hormone. It is a growth factor. It actually works through the IGF-1 receptor and also can work through the insulin receptor. The receptor listed here is just a degradation receptor. There are really not very much in the way of mutations. IGF-1 is a highly conserved protein, but its receptor is not highly conserved. There is significant variation in its receptor, and that variation represents variation in its biological ability, potency, and indeed the difference between mutts and jeffs, the IGF-1 receptor. So the main difference as you breed animals into different sizes, particularly dogs here, is variations in the function of the IGF-1 receptor. IGF-1 levels rise, as you can imagine, peaking about the time one is growing the fastest, and then they decline with age. Whether that's bad or good is some controversy. IGF-1 itself is growth hormone regulated, but not only growth hormone regulated. It is also substrate regulated as well. So starvation will cause a fall in IGF-1. Actually, we won't get it. It also causes a fall in growth hormone production as well. But it will, independent of growth hormone, cause a fall in growth hormone of IGF-1 production. And also, and this slide just illustrates that. It's not a very good slide, other than it shows that days of refeeding a starved animal, you see increased IGF-1 levels as we see increased nitrogen balance. And this is an animal that has no growth hormone whatsoever. And in fact, we've seen massively obese children who don't have any growth hormone but have abnormalities in their hypothalamus where they have decreased satiety and eat, and they can grow normally because they have normal IGF-1. Here's a picture of a little child who's growth hormone deficient. As you can see, this is a normal growth curve shown with the black dots, but this child was, as shown in the white dots, was short, but for their chronological age, but when given growth hormone, returned to normal growth. And this is a very commonly used therapy for growth hormone deficient children, because recombinant growth hormone is abundantly available, being abused by athletes around the world, and so I guess that's a major source of selling the stuff. So what are the causes then of growth hormone deficiency? They're genetic, and we'll show you examples of that a little bit later, but not to remember anything, I don't think, except that you can have genetic abnormalities that affect just growth hormone itself or the entire pituitary, and obviously you would be growth hormone deficient. Tumors that destroy the pituitary can result in growth hormone deficiency, and it's one of the, you're going to have inflammatory diseases, which we'll talk about. So a lot of chronic granulomatous diseases such as sarcoidosis, tuberculosis, or autoimmune diseases can cause abnormalities and destroy either isolated or the various variations in growth hormone. We'll talk about this more later. And of course, vascular diseases can also, an aneurysm of the circle of Willis can invade the pituitary, or one can have a ischemic necrosis of the pituitary. And then functional, which is very interesting in the case of growth hormone. For example, emotionally deprived children drop their growth hormone and stop growing. If you take them out of an emotionally deprived situation, put them in a nourishing, nurturing environment, their growth hormone returns to normal. And obviously you can have hypothalamic diseases, and you can have diseases of the pituitary. These are merely as a schematic. And here we go as an example of these. Notice, look at all the genes that have been involved in anterior pituitary development that have, of course, you can lose the entire pituitary, and so including growth hormone. You can have abnormalities in hypothalamic control. You can have growth hormone releasing hormone receptor absence, or growth hormone gene itself can be absent, etc. So there are many sites at which you can have growth hormone deficiency. How do we diagnose growth hormone deficiency? Well, unfortunately, growth hormone measurements are rather unreliable tests of growth hormone, because the growth hormone can range from almost non-detectable to reasonably high levels in the normal individual. Exercise, sleep is a very common cause of, in early sleep, growth hormone levels normally rise, so sometimes we try to measure growth hormone during early sleep. Sometimes we run the kids up and down the steps, 3 or 4 flights of steps, and get them very stressed, and that can do it. In other words, exercise and sleep will stimulate growth hormone secretion. We can measure the product of growth hormone secretion, IGF-1, as a measure of growth hormone secretion, and that's useful. And then there are a number of tests like insulin-induced. Remember, if insulin gives you, growth hormone is one of the counter-regulatory hormones, and therefore, if you give insulin, make the patient hypoglycemic, growth hormone levels will rise. And there are a number of the tests. I really, my own self, think that you don't need to remember this at this point. You just remember that you need to understand that growth hormone itself, if you look for deficiency, you must do something to stimulate it. You must ask, is it appropriately high under appropriate stimulation, as opposed to just measuring the normal level, because the normal level is often low. So growth hormone, also we can get the same defect from growth hormone, just as we can start from the cortex with emotional deprivation all the way through the pituitary as to causes of growth hormone deficiency. We can get a very similar phenotype if we have a growth hormone receptor deficiency, right? So if you don't have growth hormone, if you have growth hormone deficiency, both the growth hormone and IGF-1 are decreased. But if your growth hormone, if the receptor of the growth hormone is decreased, then we'll have IGF levels will be decreased, but growth hormone will actually be increased. Because remember, I pointed out that there was a negative feedback of IGF-1 on growth hormone production. If I didn't, I should have. So is again, always we can find in endocrinology a negative feedback loop. So IGF production interferes at the level of the pituitary on further growth hormone production. So the consequences of either growth hormone or growth hormone receptor deficiency are short stature, poor muscle development. The children tend to be obese or at least chubby and have an increased fat to lean body mass, and they have poor bone development or osteoporosis. And this is a growth hormone deficient child. You can see that as compared to, not, you can't tell, but they are they're short stature, and they have increased subcutaneous fat and less lean muscle mass. Here is a familial family of, these are people from an area of South America where there is an inborn group with a large number of inheritable deficiency in IGF-1 the growth hormone receptor. So these children are IGF-1 deficient, but growth hormone levels are actually high. It's very interesting because their longevity is normal. They have virtually no cancer, a very low incidence of cancer, and they have a very, interestingly, they have a low incidence of diabetes. But it does not extrapolate into longer longevity. The actual increase, the difference in longevity is based by they have an increased incidence of accidental death. Don't tell me why, but it's important. It's an important finding because there's a lot of research in this institution about the role of IGF in longevity, the role of IGF in cancer, and the key thing is the consequence of IGF deficiency, or in this case, again, an initial growth hormone deficiency seems to be mainly short stature. On the other hand, look at this growth chart of another child. So here we're looking at weight at the bottom, height at the top. And notice here's a child that's got a weight right in the 50th percentile for normal height at the age of about 5. And then at 6 and 7, they begin to trend up and then come off this curve. And of course, weight follows. Now, this person was a patient we had here, and this was interrupted and treated. Here's someone in whom it wasn't treated ever, because it's 1936 and nobody knew much about all this. And this is the Alton giant from here in upstate New York, 8 feet 11 inches at his death, the tallest person ever recorded. Here he is at high school graduation. This is the tallest woman, 7 feet 5 inches. So for this to happen, this is obviously growth hormone excess, and it has to happen before puberty, before bone fusion occurs of the long bones, which occurs about the time of puberty. This guy died, as did most giants. They die young. It was Andre the Giant. He was a very famous wrestler. I started showing this picture back when he was actually wrestling, and in the class, being the intellectual group this medical school class is, they were really big on watching wrestling. It was a very common occupation for the class, but I guess you don't watch Andre the Giant anymore. He's long gone. Here's a set of identical twins published in the New England Journal of Medicine. They're 22 years old, and you can see one of them is taller than the other. He also has bigger hands and bigger feet, and you can see a little what we call prognathism, which is extension of his jaw sticking out. All right? And this is a very interesting control of too much growth hormone in one and not in the other. This one had a growth hormone secreting pituitary tumor. This is 1887 Oscar Minkowski. I think he also discovered diabetes, and he drew what we call acromegaly. So if the growth hormone excess occurs after puberty, instead of getting a complete giant, you get height is fixed, but the acral changes occur, increasing of the broadness of the hands, of the feet, frontal bossing with increasing of the sinuses, prognathism with an extension of the jaw out, overgrowth of the mandible, essentially. And that's what we see. And that's the common disease. Most pituitary tumors occur, most growth hormone secreting tumors grow after that. And this is taken from a textbook by one of the most famous endocrinologists and neurosurgeons ever, named Harvey Cushing. And his, by the way, the book is a textbook on by Davidoff and Cushing, a description of acromegaly in the more modern world. And Leo Davidoff was the first head of neurosurgery at this institution. And the Leo Davidoff Society is a society honoring excellent teachers in the institution. So acromegaly, the usual age of diagnosis is around 42, as opposed to gigantism, which has to start much, much earlier in order to get height. It's usually a subtle disease, and there's a long delay in diagnosis. You see the acral features, which of course is how we diagnose this. Hyperhidrosis, sweat. They have hypertension, entrapment neuropathies because of the proliferation of tissue. Arthritis, it's not a true, it's cartilage overgrowth in the joints, which lead to disarticulation and joint problems. They have headaches, of course, if the tumor is big, and hypopituitarism. And growth hormone has anti-insulin actions, so it basically is an anti-insulin. It opposes the action of insulin. It also stimulates lipolysis. So acromegalics often have diabetes and can have ketoacidosis. Acromegaly may be due to a small pituitary tumor. Notice, here we go, if you remember the previous ones, you can see instead of this nice bean shape, we've got like a little ball at one end of the pituitary, and the stalk is pushed to the opposite side. And this would be a classical example of a pituitary microadenoma. An adenoma that's less than 1 centimeter is called a microadenoma. If it's greater than 1 centimeter, it's called a macroadenoma. Here's a macroadenoma. As you can see, pushing up, pushing towards the cavernous sinus on either side. This is just a sagittal section of that same tumor. How do we diagnose acromegaly? Well, in the normal pituitary, if you give a glucose load, you will stimulate the secretion of somatostatin, as you do in the pancreas. Somatostatin secretion from the pancreas, where we can easily measure it, is very much stimulated by glucose, and it is also in the hypothalamus, and that release of somatostatin lowers growth hormone in a normal person. In an acromegalic, because these are monoclonal tumors, and because all tumors tend to have to induce angiogenesis, the supply of blood from that tumor, even though it's in the cell, is most likely going to be arterial from the angiogenesis that's generated, and therefore it doesn't see the somatostatin coming down to the hypothalamus, or it doesn't see it properly, and therefore you see non-suppressible growth hormone. That's a classical, and this is a board question, not even on endocrinology, it's a board question usually in just general taking your boards when you finish medical school. So typical, I don't know it anymore, but used to be almost every year. Another thing we can do is follow IGF-1 levels. And you can see they're elevated compared to normal. And it's interesting, as I said, these are monoclonal tumors, and about 20 or 25% have an activating mutation of the heterotrimeric G protein G sub S, because growth hormone releasing hormone stimulates through the cyclic AMP formation through the classical G protein mechanism to activate both cell proliferation and growth hormone secretion. And a mutant activating mutation, of course, means, and probably that's the 25%, the other 75% probably have mutations somewhere else along this pathway, though that would be a classical way. We just don't know them. How do we approach it? Well, remember I told you about that little sphenoid sinus where you can go either endoscopically or through into there and take it out. And here we see a growth hormone patient who has very high growth hormone levels. We can take out the tumor, and then we see very, very low growth hormone because the IGF is IGF, high IGF is negatively fed back on the normal somatotropes, and they are suppressed and atrophic, but they normally recur. And then look at this. At the bottom of this slide, you see what a normal profile of growth hormone secretion would be. Notice that with each meal, protein-containing meal, if it was a glucose-containing meal, the growth hormone would go down. But if you give protein, you actually stimulate. So with each meal, you get a little burst. And then look at this when you sleep, early sleep. And that's one of the places we can look for growth hormone to be normal. Remember I said that somatostatin analogs could be derived, and here is the use of one of those called octreotide, and the white spots are the growth hormone before, and the black is after they take or chronically on this drug, and you can see that it's effective to some extent. We also can design. Here's the slide I showed you earlier about how growth hormone dimerizes two growth hormone receptor molecules forming. It's like a activated cytokine-like receptor through the MAP kinase stimulating growth IGF-1 formation. But you can design a growth hormone receptor antagonist by taking something that has a higher affinity for the receptor than the native material, but also delete one of the sites. So now it just binds all the single receptors and doesn't allow them to dimerize, and now you have a receptor antagonist. These are both strategies we use in treating this disease. And in the next few minutes, so I'm going to go another about 10 minutes, 5 to 10 minutes, and then stop for a little bit, and then the last section will be much shorter. Okay, so all right, so we'll be through by 10:30, but you get to a little more at the first and a little shorter at the second lecture. So now, remember we've talked about dopamine as being the main regulator of prolactin secretion as a negative feedback system. Prolactin's main act is required for lactation. It does not cause gynecomastia. It does not cause the breast to enlarge. It only causes the breast to make milk. Many other factors are involved. You must have estrogen. You must have other factors. But without prolactin, you cannot make milk. Prolactin is regulated by dopamine. It's also regulated by estrogen, but in a totally different method. Dopamine is an inhibitory factor to prolactin secretion. Estrogen is a stimulus for the proliferation of prolactin-secreting cells. And indeed, during pregnancy, when the estrogen levels are very high, the number of prolactin-secreting cells goes up dramatically in the pituitary, enough to enlarge the pituitary and make it actually grow substantially in size during pregnancy. Also, suckling has some effect on stimulating lactation. So, what are the causes of too much prolactin? Too little prolactin simply would mean no lactation. Physiological causes, normally levels are around 5 to 20 in pregnancy, normally due to the proliferation of prolactin secreting cells. The values can go up to as high as 350. In hypothyroidism, for some reason, maybe, I don't know why, it goes up a little bit. Its degradation or is impaired by renal failure, so you can get high levels there. Drugs, the drugs that are anti-dopaminergic, any drug, a lot of drugs that are used for psychiatric care are anti-dopaminergic, and indeed they stimulate growth hormone. Tumors are the other cause. Supracellular lesions can, by inhibiting the flow of dopamine to the pituitary, by blocking the pathway, can elevate up to 350, but usually much lower, but as high as 350. Microadenomas can go from 3 to 500. Macroprolactinomas, 100 to 30,000. So when you see values of above 350, you know you have a tumor. Okay? That's the bottom line. Below that, there are a lot of other possibilities. So what does too much prolactin do? Prolactin inhibits LH and FSH secretion. So not only do you see non-peripheral lactation, called galactorrhea, but we also inhibition. And what is the sense in that? It is the natural contraceptive. You know, evolution has told us that the chance of extending DNA is best if a mom has a little break between pregnancies. I imagine any of you in this room who've had children will know that's true. And essentially, particularly where nutrition is borderline or marginal or not dramatically affluent like it is in this country, as long as a woman nurses, she will continue to produce lactation, prolactin, and will stay amenorrheic for up to several years. In this country, with good nutrition, despite breastfeeding, prolactin returns back to normal, and after a few months, and fertility actually can be restored while you continue to lactate. So here are prolactinomas. You can see it's the same story with growth hormone. You can have microadenomas or macroadenomas. Here you see a dramatic one. Dopamine, as we said, is the key one, and irrespective of whether it's physiological or tumor developed, if you give a drug systemically, which therefore gets to the hypothalamus or to the tumor, you can dramatically lower prolactin levels. And the most amazing thing, what happens is there's up to 50% reduction in not only does it lower the prolactin level, but the tumors shrink. And it's a little like, the shrinkage is interesting. It's a little like turning a raisin into, a grape into a raisin. Namely, all you do is you're depleting the tissue of these multiple secretory vessels that contain prolactin, and you get shrinkage down. If you stop, or if for a macroadenoma, it's a plum into a prune. You know, these are the analogies I'm using. If you stop the drug, they come right back. All right? If you do it for a number of years, the tumor eventually dies off, typically, but not guaranteed, okay? We have patients that have 20,000 prolactins who get down to 50 to 100 chronically with their tumor going down. Here, for example, here's a sagittal and coronal section of a patient with very large macroadenoma. You can see it here. And this is what's seen after a year on drug. You can't even see it virtually. You see like a little rim of it here. Okay, that's where I wanted to stop because we're going to now talk about some diseases of the pituitary in general, including pituitary tumors and other diseases. Let's take a 10-minute break. How's that? And then from there we'll be back here. We'll start at about what time is there in the clock? We'll start 10 minutes from now, a little before 10 till, like about 12 minutes till 10. Okay? So here we show a coronal and a sagittal section of a large pituitary tumor. Notice, first of all, you can see it looks like has a waist to it because it's popped through the diaphragmatic cella, and then it has, so it's kind of, that's outside the cella starting above this. You can see the optic chiasm stretched over it. And you can see that the carotids are kind of invading the cavernous sinus. Remember, there's nothing there but dura separating the tumor from the cavernous sinus. So what are tumors likely to do? I think we've already talked that they're going to cause hypopituitarism. We'll come back to that. But first of all, the most common symptom they present is headaches, which unfortunately is not specific enough. They do that because they stretch the dura of the tumor. The pain comes from stretching of the dura. If they extend far enough outside up, they obstruct the third ventricle and can cause hydrocephalus, though this is a very rare symptom. The most classical symptom is visual field defects, because they push up on the lower portion of the optic chiasm and result in something called bitemporal hemianopsia. We'll talk about that a little bit more. And because they extend into the cavernous sinus, they can cause cranial nerve palsies. And finally, they can push down through the floor into the sphenoid sinus and result in cerebrospinal fluid rhinorrhea. So you get leakage of spinal fluid into the nose. And I can assure you that I've seen examples of all of these. I've also seen examples of people who've had strokes, probably because of compression of the carotid artery of the tumor. The bitemporal field defect has to do with, of course, what you already know, I hope, about the fact that the optic chiasm, essentially the reflections of the medial aspect of the retina, which of course are looking at the distal field, are the ones that cross over, desiccate at the level of the optic chiasm. Here's a patient with a third nerve palsy secondary to a tumor extending into his left carotid cavernous sinus. See his eye is deviated to the left, drooping lid. And again, as I've already mentioned, the classical approach is surgery. In addition to surgery, there's other therapies. There's radiotherapy, and of course, for those tumors that are functional, that particularly prolactinomas, the the treatment of choice is not surgery, but to use dopaminergic agonists. I hope I've made that point clear. We no longer operate on prolactinomas except rarely. And by the way, prolactinomas are the most common. Of all the pituitary tumors, 40% of them are prolactinomas. Now, there are many other tumors or many other things that can affect the tumor, the cellular. So non-prolactinomas, non-pituitary tumors like craniopharyngiomas, chordomas, inflammatory diseases like sarcoidosis, metastasis to the sella, granulomatous disease, mengiomas, pseudotumor cerebri. These are things that can enlarge the sella. Here's obviously a CAT scan showing a tumor. I think you can just see that it's really not arising inside the sella, which is here. Here's a disease which is affecting the stalk. Look how wide the stalk is, how intense it is, and how the pituitary. This is a patient with sarcoidosis. Remember, the other thing about blood-borne diseases, whether they be metastasis or inflammatory, they have to pass through that capillary portal system to get to the pituitary. So they're going to, almost by definition, involve the hypothalamus. So they're going to involve the hypothalamus, whereas the primary tumors of the pituitary spare the hypothalamus. So what are the pituitary diseases? Mass lesions, we've kind of covered that. Tumors, whether they are large or small, that secrete typically things like acromegaly, prolactinomas. As you'll see subsequently, ACTH secreting tumors cause Cushing's disease. Very rare TSH producing tumors cause hyperthyroidism. But these are very rare. ACTH producing tumors are not. Prolactinomas are the most common. Cushing's and acromegaly, I don't know, probably they're pretty similar. Hyposecretion, in other words, destructive lesions. You can have isolated deficiencies or multiple deficiency. And there's something called the empty cella syndrome. And I just thought we ought to define what that is for you, because you'll read about it. Obviously, if you remove a tumor from the sella, or the sella undergoes complete, the pituitary goes complete necrosis and disappears, you will have an empty sella, because the sella contents mainly are the pituitary. But the sella itself will be of normal size, and that's called, for the most part, that's called a secondary empty cella syndrome. But the primary empty cella syndrome, as stated here, is this is normal. You have the anterior pituitary and the posterior pituitary occupying the sella, the diaphragmatic medulla. But if you have holes in the diaphragmatic sella, you can herniate in an arachnoid cyst, which is filled with CSF, pushes the normal pituitary over to the side, remodels the sella so the sella becomes large. So a large sella with nothing in it is called a primary empty cella syndrome, and for the most part is of no particular consequence. So what are the causes of hypopituitarism? Well, we've really gone through this when we talked about the causes of low growth hormone, because congenital defects may not only involve growth hormone, they may involve any one of a number of hormones produced by the anterior pituitary. Tumors, be they adenomas, craniopharyngiomas, paracellular tumors, or metastatic tumors, can also, of course, cause hypopituitarism. Inflammatory diseases, again, we've mentioned all of these: sarcoid, tuberculosis, an autoimmune disease called hypophysitis, histiocytosis X, and then vascular Sheehan syndrome. Sheehan described an interesting disease occurring in pregnant women who at the time of delivery underwent hypotension from blood loss. We just had 2 cases appear before us recently. It's very related to poor obstetrical care. Another hemorrhage relates to poor obstetrical care. And if they become hypotensive, this sella, this pituitary gland, which is now twice its normal size virtually for all that proliferation of the prolactin cells, it's got a low volume blood supply, the portal system. It's not an arterial supply, and it's very susceptible to necrosis from ischemia. Apoplexy would be bleeding into the pituitary. Usually, even a small pituitary tumor or hemorrhage into it can cause a syndrome called pituitary apoplexy. Usually, severe onset of a headache. If it destroys the pituitary, the patient has a number of symptoms due to collapse of their ACTH axis, and they get hypoadrenal. And aneurysms can actually and also invade it. So these are the causes of hypopituitarism. So if you lose your pituitary, if you lose your posterior pituitary, you have a disease called diabetes insipidus, prolactin loss, failure to lactate, growth hormone, of course, hypoglycemia, short stature, TSH, decreased energy, poor memory, cold intolerance. You're going to talk about each of these hormones except the growth hormone and prolactin. And of course, ACTH loss leads to lack of well-being, poor appetite, hypotension, low sodium, decreased body hair, and growth hormone, of course, we've talked about. Here is a famous picture by Ralph Nader, famous medical illustrative, talking about a patient with panhypopituitarism, the mass facies of a patient with hypothyroidism, the absence of body hair. In the female, sex hair, namely axillary and pubic hair, comes from production of male hormone by the ovary and from precursors made by the adrenal, which is converted into androgen. And that's the source of that. In the male, of course, now it's the absence of testosterone, leading to lack of axillary and pubic hair and that. So here we look at, again, I think we've already covered this short stature replacement. Here's, again, identical twins, New England Journal of Medicine. Which one of these twins has hypopituitarism? Anybody want to? The one on what? This would be the right on this side? Yeah. You're right. You're right. You say that one is the one? Anybody want to think it's the left one on the left? All right. So look at the difference. No hair on the chest. This guy has temporal recession. This is androgen-induced balding. He doesn't have it. He's a little heavier, a little fatter. Okay? His lean body mass is less than this one. And that's exactly right. Here's a woman with Sheehan syndrome. You can see she looks like exactly like the picture that Nader is drawing. This is a patient of ours. Okay. So that's hypopituitarism. Now, again, this slide is illustrating what we've already mentioned before. The posterior pituitary essentially is a terminal neuron axon coming from nerve bodies in the hypothalamus producing ADH. And when ADH is produced, it's by axonal flow, it slowly migrates to this point, and it's during that axonal flow that the hormone is processed and made into mature hormone. And there it sits at the end of the axon, waiting for the stimulus sensed up here in the hypothalamus to send it down and tell it to secrete. Now it turns out that all that's required for this to be workable is that the axon is long enough to allow that processing to go on. So you can take out, you can cut it off right here, cut it off right here and that it'll still work. You won't get any problem with ADH secretion or oxytocin secretion. But as you cut further up the axon, it won't work. Now, the ADH is a very simple peptide, but it's biosynthesized in the nerve body in conjunction with a much larger protein called neurophysin, and they are produced as a single peptide, and then they are split over time down in doing this axonal flow, and the neurophysin more or less serves as a chaperone for the lack of to prevent the destruction of the vasopressin or ADH. It's the same thing. And the important point about the neurophysin is to say that of the mutations that cause mutations causing congenital lack of ADH. Most of those mutations have actually been described actually in the neurophysin molecule. So that neurophysin is, even though it's a prohormone, part of the prohormone, it is essential to the natural maturation and processing of the vasopressin itself. So vasopressin there are 3 receptors for it. One is a vasoconstriction receptor operating. Another one is either vasopressin 3 or 1B, which stimulates ACTH release. We've already talked about that, which is separate from this or this. And a V2, which is essentially is on the basolateral membrane. It's a cyclic AMP dependent function, and it inserts water channels in the apical membrane and is critical for, works right here, and it makes the distal collecting tubule permeable to water. So we generate free water. We generate free water here in the distal nephron diluting segment of the distal nephron. This free water enters. In the absence of ADH, we pour it out. In the presence of ADH, we reabsorb it. So in general, what happens is if we increase our plasma osmolarity or decrease our arterial circulating volume, 2 things happen. Osmoreceptors in the hypothalamus sense and stimulate the concept of thirst, which tends to lead us to increase our fluid intake, and also secrete AVP, arginine vasopressin, which causes increased permeability for water in that distal collecting tubule, and we reabsorb that water and essentially concentrate our urine. Diseases that involve the hypothalamus, not the anterior pituitary, because remember I said you don't need a posterior pituitary, but diseases such as sarcoidosis or other blood-borne diseases classically, or tumors if they get large enough, involve the hypothalamus, can cause destruction of these nerve bodies. So as I have to say it many times, the nerve bodies are in the hypothalamus, not in the posterior pituitary. So patient with diabetes insipidus, that is this patient who does not have any antidiuretic hormone, cannot retain water. They will pee a lot. So the commission must develop a differential diagnosis for somebody who complains of, I'm going to the bathroom all the time, doc. And the first thing you want to know is it really true that they're producing large amounts of urine? So you could ask them to collect a 24-hour urine, and it may turn out to be reasonably normal or only modestly elevated. They don't have diabetes insipidus or any abnormality. They're just someone fixated on going to the bathroom too much. Maybe they have a bladder problem or something that makes them need to urinate a lot, but there's nothing wrong with their system. There is a condition in which patients with diabetes insipidus can produce up to 10 liters of water a day, of urine a day. So anything short of 3 or 4 liters a day, 3 liters a day, probably is not diabetes. Short of 2 liters a day at least is certainly not diabetes insipidus. So it can be normal. There's a condition called primary polydipsia. The primary polydipsia is an obscure etiology in which people drink large amounts of water, have intense thirst, and drink all the time, pee all the time, can produce large volumes of urine. However, if you restrict their access to water, they will normally concentrate the urine. We'll show you that in just a second. Then there's neurogenic diabetes insipidus. That is a disease in which you don't have antidiuretic hormone. And then there's nephrogenic diabetes insipidus, a disease in which the ADH doesn't work. So how do we tell all these conditions apart? So here is a study in which what we do is we increase the plasma osmolarity. You could do this by just simply holding the patient access to water and let them suddenly dehydrate so that they will become, their plasma osmolarity will rise. Or you could give them a hypertonic saline or something to make them do this. And in a normal individual, what will happen is as their plasma tonicity rises, their plasma ADH would go up, and this would be illustrated on this curve. If they have central diabetes insipidus, no matter how high, can't make ADH, obviously, as their osmolarity goes up, their plasma ADH level would not. If they have nephrogenic DIN, they're already making a lot of ADH, and of course even go higher. So we don't really usually use this test, we use this one. And this is an easy test to do, though you have to be careful. And that is, we take and we bring the patient in and have them not just fast, that is to say, no fluid. So most of you who've had to fast for a period of time will know you get pretty thirsty and you cut back on your urine flow. And that's what happens. Urine osmolarity and volume, therefore, will rise. And the maximum uosm is about 1,000, but usually around 500 is about as good as we usually do. A desert rat can get up to 1,000. And what's happening is all the water is being reabsorbed, and what's happening is in the urine, the only thing that's in urine is very high concentration of sodium and urea, which are the particles that contribute to the osmolarity. If you have central diabetes insipidus, then you don't raise your urine osmolarity, but then when given ADH, it corrects. Your urine osmolarity goes up. This is a classical feature of central diabetes insipidus. Where if it's nephrogenic, when you give the ADH, it does not go up. So this is the test we use to separate these. Now, some people feel that the so-called primary polydipsia is simply a new set point, which is one in which the thirst mechanism and the secretion of ADH is a little off kilter. So you get thirsty before you start secreting your ADH. So therefore you keep drinking water and you put out a lot of urine. And some people think it's a psychological disease, some think it's a little different set point between, just a discordance between the thirst mechanism and the set point to secrete ADH. I don't have any idea which it is. So now I'm going to show you an interesting, what would happen if you took and go in and removed the lesion high up in the hypothalamus so that you're going to essentially ruin the ability to make ADH. Immediately what would happen is you would not have any ADH around, and urine volume would therefore rise precipitously. That would be the acute set. Now those neurons that are there would degenerate by Wallerian degeneration, correct? And all the stored ADH they had in them would leak out, correct? And then you'd go through it, and suddenly this would reverse. And you'd go through a phase in which you had too much ADH, and urine volume would fall a lot. Then, after that stored, it's no more going to be made, and what goes away, then you come up and have permanent diabetes insipidus. Is that clear to everybody? Not that that's so, it's just pretty straightforward. So here is a Brattleboro rat he has congenital absence of antidiuretic hormone. All right? So he's a big-time peer from the day he starts. I wouldn't want to take care of the cages that these rats would be in. If you take out their pituitary, the diabetes insipidus either goes away or greatly improves. And what is the mechanism for that? I'm sure that you've all figured it out from the course questions today, right? It turns out that thyroid hormone and cortisol are necessary for generating free water. The mechanism is not totally clear, whether it's a direct effect of these agents on the place in the kidney where free water is generated, namely the cortical diluting segment, or whether it has to do with changes in GFR or whatever, so there's less solute delivered to generate free water. I don't know, but it's a very clear thing. Okay, I'm finished. Thank you. That's my day. That's it for us. Okay. I'll be happy to be here. I'll stay here for the next 10, 15 minutes if anybody has questions.